Hey everyone, and a very warm welcome to the MediByte channel. I'm your host and a healthcare professional, and I am so excited to guide you through today's explainer. We're diving into a medical topic that affects so many people, yet it's often completely unnoticed or just plain misunderstood: cervicitis. Whether you're currently studying healthcare or you just want to know a bit more about how the human body works, you are in exactly the right place. We're going to take these clinical facts and break them down into bite-sized, easy-to-digest concepts. Okay, let's take a quick look at our roadmap for today. We'll be figuring out what exactly cervicitis is, uncovering the causes, learning how to spot the symptoms, discussing the very real risk of PID, and finally, looking at diagnosis and treatment. So, first things first, let's cut through the medical jargon. What exactly are we talking about when we say cervicitis? To really wrap our heads around this, we just need a quick anatomy refresher. The cervix is that lower, narrow part of the uterus that opens directly into the vagina. I like to think of the cervix as a sort of gateway to the upper reproductive system. Cervicitis simply means this vital gateway has become inflamed. Just like a scraped knee or a sore throat, when the tissue in this area gets irritated or infected, it becomes swollen, red, and highly sensitive.
Now, you may be wondering, what on earth actually triggers that inflammation at the gateway?
Well, it's pretty interesting, actually. We can basically split the causes into two distinct camps based on how fast they happen. If cervicitis comes on suddenly, we're almost always dealing with a fast-acting, invading infection. But if the inflammation has been lingering for a long time, meaning it's a chronic issue, it's usually not an infection at all. These slower, non-infectious reactions are typically chemical or allergic. We're talking about things like diaphragms left in the vagina for too long, harsh chemicals in certain douches or contraceptive creams, or even just a standard allergy to latex condoms. However, those sudden, infectious invaders, they are way more common. The vast majority of acute cervicitis cases are actually triggered by sexually transmitted infections. Chlamydia is the absolute most common culprit here, followed closely by gonorrhea in second place. We also see genital herpes playing a role, along with a bacteria called Mycoplasma genitalium. And it's worth noting that everyday imbalances in the vagina, like bacterial vaginosis, which is just an overgrowth of normal bacteria, can sometimes spread and irritate the cervix too. Okay, so say those invaders have breached the gateway. How would a patient even realize they have cervicitis? Well, here is the absolute kicker, and honestly the scariest part. Most of the time, there are zero warning signs. Literally none. It's a classic iceberg situation where the real danger is hidden beneath the surface. A patient could feel perfectly fine while the inflammation is actively raging on. It just sits silently at the cervix, which makes this a really deceptive hidden thread. But when symptoms do decide to show up, they manifest as these very specific, highly uncomfortable warning signs that you absolutely should not ignore. The most common one is an unusual discharge that can sometimes look yellow, green, and pus-like. Another huge red flag is vaginal bleeding that pops up unexpectedly between periods or after sex. Patients might also feel noticeable pain during intercourse and see redness and irritation right around the vaginal opening. And if the infection has already started causing pelvic inflammatory disease, things like a fever and lower abdominal pain might join the party too. And that naturally brings us to a much bigger problem. What happens if those symptoms are ignored or just never show up in the first place? Let's map out how this builds if it's left untreated. It's essentially a ticking clock. Day 1, the infection enters the vagina. By day 3, it hits the cervix, giving us the cervicitis we're talking about today. But if it isn't stopped at that gateway, the bacteria just keep marching higher. By week 1, the infection can spread up to the lining of the uterus, and by week 2, it's invading the fallopian tubes and ovaries. Once it hits those upper reproductive organs, it officially crosses the line into pelvic inflammatory disease, or PID. I really can't overstate how serious this upward spread is. PID is actually the most common preventable cause of infertility in the United States. Women who develop PID often face severe difficulties getting pregnant later on. This is a condition that overwhelmingly impacts sexually active women. You very rarely see it in young girls before their first period, during a pregnancy, or after menopause. To truly put this into perspective, let's look at the sheer destruction PID leaves behind. First, it creates these abnormal bands of scar tissue called adhesions, which can completely block the fallopian tubes. Then you have the risk of peritonitis, a really serious infection of the abdominal lining. If the original infection was gonorrhea or chlamydia, it can even cause something called Fitzhugh-Curtis syndrome, where the infection spreads all the way up around the liver, feeling exactly like an intense gallbladder attack. PID can also form dangerous pockets of pus called abscesses. And finally, because of that scar tissue we mentioned, a fertilized egg might get trapped in the tube, resulting in an ectopic pregnancy. This happens 6 to 10 times more often in women who have had PID, and it's a massive medical emergency for the mother.
All right, enough doom and gloom. Let's talk about the action plan. How do we actually catch this and defeat it?
The good news is, getting diagnosed is a super predictable, non-scary visit to the doctor. It starts with a standard evaluation and a routine pelvic exam. During this, the doctor will actually touch the cervix gently with a swab. If the cervix bleeds easily and there's a pus-like discharge, cervicitis is basically a guarantee. They'll use that same swab to send a sample to the lab to figure out exactly which bug is causing the trouble. But step 4 is absolutely critical. The doctor won't even wait for the lab results. They will start antibiotic treatment immediately right then and there to halt the infection and prevent all those severe PID complications we just talked about. This chart brilliantly illustrates how specific antibiotic heroes are matched to defeat their exact infectious villains. For chlamydia, we're looking at oral antibiotics like azithromycin or doxycycline. Gonorrhea requires a bit of a combo punch, usually an injection of ceftriaxone directly into the muscle plus oral azithromycin. Now, if the test comes back and it turns out to be the herpes simplex virus, that's a bit different. That virus is for life, but doctors will prescribe antiviral medications that do a fantastic job of controlling the infection, even if they can't completely cure it. But wait, getting rid of the infection in yourself isn't the whole shebang. There are some very strict rules to prevent reinfection. Sexual partners have to be tested and treated at the exact same time. If they aren't, the partners will literally just pass the bacteria back and forth. You also have to completely abstain from sexual activity until both you and your partner are totally cleared. And lastly, for chlamydia and gonorrhea, you absolutely have to go back and get retested 3 months later. Why? Because reinfection is incredibly common, and we have to be absolutely positive that gateway is secure.
Which brings us right back to our biggest takeaway today. Just look at this quote straight from the MSD manual. Because cervicitis often causes no symptoms, it may be diagnosed during a routine pelvic examination. So here's a thought I want to leave you with. Are you prioritizing your routine checkups, even when you feel perfectly fine? Because as we've learned today, feeling fine does not always mean the gateway is safe. Sometimes a routine exam is literally the only shield you have against a silent threat.
Thank you so much for hanging out with me for this explainer. As a healthcare professional, my absolute favorite thing is giving you the clear, structured knowledge you need to advocate for your own body. If you found this breakdown helpful, please hit that like button, share this video with anyone who might benefit from it, and don't forget to subscribe to the MediByte channel for more deep dive medical explainers. Stay curious, stay healthy, and I will see you in the next one.